Is it visible to you?
Yes, yes, yes. I can.
Yeah, sir, you can start your presentation. The panel is all yours.
Okay, thank you. Thanks to Stride 21 for this big platform. And I think it's one of the best arrangements, and the organization have done a best job for this. Okay, let me start for this presentation. Okay, I have selected the topic as thoracic outlet syndrome. Next slide, please. And in this session, I would like to talk about just to have an outline about what is the definition of thoracic outlet syndrome, and to analyze the causes of thoracic outlet syndrome, discuss types of thoracic outlet syndrome, to review myofascial chains related to thoracic outlet syndrome. Next, please. Okay, I would like to start from what is syndrome, because the syndrome is different from the conditions or clinical manifestations. Syndrome is defined as a group of signs and symptoms that collectively characterize or indicate a particular disease or abnormal condition. Because it's a bit different, we cannot have particular signs and symptom as a syndrome. It's a collection of signs and symptoms which are forming a syndrome. Next, please. Especially in thoracic outlet syndrome, it's a collection of syndromes which are brought about by abnormal compression of the neurovascular bundle by bony ligamentous or muscular obstacles between the cervical spine and the lower ribs or lower basements. Sorry, next slide, please. So the concept is it's a mechanical predisposition and it's a mechanical space problem. This restriction of space precipitates the symptoms complex of thoracic outlet syndrome. And this neurovascular bundle, what I meant, it's getting the compression consists of brachial plexus, C8 to TM, and nerve roots and subclavian arteries and veins, which are passing through the thoracic outlet. And this outlet is being compressed by the various structures which are adjacent to these areas. And can you go to the next slide, please? The first one, as I mentioned, various syndromes. This is the first syndrome, which is called anterior scalene tightness. When there is a compression of the interscalene space between the anterior and middle scalene, muscles probably formed from the nerve root irritation, spondylolysis, or facet joint inflammation leading to a muscle spasm. So when this muscle spasm happens, it starts compressing the structures beneath it. Next, please. And the second one is cervical rib syndrome. It's a variation of scalenus antecedent syndrome. It is an osseous anomaly, not a muscular hypertrophy, and it is responsible for the compression. Cervical ribs are hereditarily elongations of transverse process of the seventh vertebrae. They may be unilateral or bilateral. We'll talk about the cervical rib syndrome in the later slides. And the next one is costo-clavicular approximation, compression in the space between the clavicle, the first rib, and the muscular and ligamentous structures in the area, probably from the postural deficiencies or carrying heavy objects, or the reasons for this costo-clavicular approximations. And another one is compression beneath the tendon of the pectoralis minor, where pectoralis minor under the coracoid process may result from repetitive movements of the arms above head, like a shoulder abduction syndrome, because these things are called as, if you see now, I have come in the series like from the proximal up to the distal. These are the 5 to 6 areas where the compression can happen to the neurovascular bundle. Next, please. And when I spoke about the costo-clavicular space, this overuse of the scalene and the other accessory respiratory muscles may result in an elevation of the first rib and rib cage, reducing the costo-clavicular space, like this picture says. Next, please. And the posterior triangle, again, it's just to give you a pictorial review about how this posterior triangle is there and how it influences the neurovascular bundle, which is passing beneath these structures. Next, please. And the last one, that thoraco-coraco pectoral space. Narrowing of the thoraco-coraco pectoral space can result from shortening of the pectoralis minor or pectoralis major muscles. Patients with thoracic outlet syndrome resulting from the narrowing of this space often present with the forward head posture or rounded sagging shoulders. This is all again related with the lifestyle, like lifting heavy weights and the postural anomalies. Again, please. When we spoke about all these levels of the compression, what can happen, we were talking about the compression repeatedly and very direct influence of the postural alterations, hypertrophic muscles, muscle imbalance, elevated first rib, presence of a cervical rib, and macro trauma such as automobile accidents, static postures and heavy loads, carrying the heavy loads, and repetitive overhead movements like hyperabduction syndrome. These are the lifestyle reasons which can cause all these symptoms or all these compressions. Next, please. Talking about the cervical rib, it's not a condition, it's actually a fibrous band extends from the cervical rib to the first rib, causing an extra bend in the lower part of the brachial plexus, which may produce a compression in this region. It is not a diagnosis, this is an anatomical feature only, which may or may not be implicated in the etiology of the cervicothoracic protective responses, leading to pain or dysfunctions, whatever we have as symptoms. But it's not a direct relationship. Next, please. As I mentioned in the previous slide, we cannot blame the cervical rib as one of the main cause, because people who have cervical rib also can escape from the symptoms. We have to consider all the other reasons for these compressions, like scalene antecedens and medius muscles, pectoralis minor muscles, costocoracoid ligament, costoclavicular membrane and subclavius muscles, those tightness. And when we talk about the bony anomalies, first rib, cervical rib anomalies, long transverse process and clavicular abnormalities, which lead on to the compression. And of course, the compression might be with various areas, with either vascular or nerve or mixed. We'll talk about these things in the next slide. Can we go to the next slide, please? As I mentioned, the types are neurogenic, which includes only the nerve issues, then arterial or venous or true neurogenic, disputed, non-specific, and common. The types are not so well outlined, and it is no specific differentiation for among these types. But so whatever we differentiate is as predominant neurogenic, predominant arterial, or predominant venous, but there might be mixed as well. We cannot isolate it into one condition as well. Next, please. According to the new classification of TOS is proposed, there are two new forms. One is the complicated and the other one is uncomplicated. It's the simplest classification I have seen for the TOS. Next, please. It is a most undiagnosed and misdiagnosed form because we don't know what is the real reason or what is really going on. We cannot blame the thoracic outlet for all these reasons. Divided in predominant neurogenic, predominant arterial, and predominant venous types again, which one of the type is diagnosed, the other two should be ruled out. The uncomplicated form can present with a broad spectrum of symptoms from mild to severe pain, with the mildest form having positional paresthesias as the only symptom. The symptoms are frequently intermittent and oscillating. We usually get in our clinics with uncomplicated form. We are not getting much of this complicated forms, but we should be having the idea about what is complicated form as well. Next, please. It's easy to diagnose, but it's too late because that's what I mentioned. We have to rule out the complicated form in our earlier days itself. Atrophy and marked weakness of the hands in the neurogenic type, arterial TOS with non-positional ischemia of the fingers and hands, thrombosis and or embolism of the arteries of the upper extremities, subclavian aneurysm and cerebral embolism are the manifestations. In the venous type, we have venous thrombosis of the subclavian and axillary veins. Pain and paresthesias of the upper extremities are common in three types. Shoulder, neck, and chest pains, facial pain, and occipital headaches are usually ignored symptoms of the predominant neurogenic type, both in uncomplicated and complicated forms. Now, we spoke about the complicated and uncomplicated forms, but what are we going to do with them? Can you go to the next slide, please? How to diagnose it is because we cannot have the proper diagnosis for these conditions. As I mentioned, it's a collection of symptoms. It's not a proper diagnostically easy condition. It's like a standardized set of signs and symptoms. It is the most common overlooked and misdiagnosed peripheral entrapment neuropathy. A diagnostic gold standard accepted by the majority of physicians is not available, unfortunately, for thoracic outlet syndrome. Of course, we have various special tests and various diagnostic procedures, but those are all to eliminate the conditions and the symptoms and to pinpoint this condition. We cannot isolately reach the conditions unless we eliminate all the rule out other conditions. Next slide, please. The diagnosis is usually confirmed by elimination of other causes with similar clinical presentation based on the total clinical picture. There are no shortcuts. A careful and even exhaustive history and physical examinations are required, together with selective testing. The diagnosis of TOS is difficult because of the intricacy of vascular and neurological symptoms. The goal should be to figure out an accurate diagnosis and not just to determine if thoracic outlet syndrome is present or absent. Because thoracic outlet syndrome, of course, why even if you have a pain in your wrist or with some tingling sensation, we can name the thoracic outlet syndrome, but we don't know what exactly is the symptom, which structure is entrapped or which structure is being compressing. Next slide, please. These syndromes have been categorized into anatomical and functional TOS. Anatomical TOS includes congenital anomalies and traumatic osseous and soft tissue injuries, whereas functional TOS include postural adaptation as a result of work or sport participation, respiratory changes, and psychological conditions. As I mentioned, these functional TOS are the one which we can modify it as a physiotherapist. Next, please. Differential diagnosis, whatever we have to differentiate, as I mentioned, to rule out or this much exhaustive list of conditions are there, starting from carpal tunnel syndrome up to the nerve root involvement, shoulder instability, malignancies, chest pain, thoracic T4 syndrome. Everything have to be ruled out and isolated before coming to the conclusion of this thoracic outlet syndrome. It needs extensive history collection and physical examination and other diagnostic processes. Can I have the next slide, please? And systematic causes, as I mentioned previously, those are the easier conditions what we remember, but we are neglecting those Pankos syndrome, radiation-induced brachial plexopathy, Parsonage-Turner syndrome, carpal tunnel syndrome with the neuropathies, fibromyalgia, and cervical disc diseases. Next, please. There is never a standard treatment can be given, as there are so many factors that can be or may not be contributing. As I mentioned, when there are different diagnoses or different reasons are present, we cannot isolate the treatment. Okay, do this stretch, do this exercises, or do this treatment for the patient. We have to first find what is really the structure which is compressing and which is being compressed, then we can go to address that. Next slide, please. What are we doing for these patients? Are we going to have that traditional pain control mechanism, which is a painkiller techniques? I don't think that will work out much. Maybe for the chronic pain patients, some modalities for the pain gate mechanism, we can use it. But usually we have to go for mechanical approach. As I mentioned, it's all related to the lifestyle and the patternings. Next slide, please. The literature suggests that variety of methods have been traditionally used to manage TOS. Encouraging relative retraction of the shoulders increases the thoraco-coraco pectoral space. Compromised sensory motor control of the posterior parascapular muscles, particularly the rhomboids, serratus anterior, and lower and middle trapezius, can alter the position of the scapula at rest and during arm elevation activities. So the scapular setting is very important, and as a physiotherapist, it's very important to know about the scapular positioning and scapular stability. Sensory motor control exercises for these muscles are begun once relative pain control has been achieved. All exercises should focus on muscular endurance rather than strength. Uh, the strength is different from muscle balancing. So try to focus on the muscle balancing rather than going for the muscle strength exercises, strengthening exercises. Next, please. Restoring mobility to the first rib can increase the costoclavicular space and reduce the imposed load on the neurovascular structures in the thoracic outlet container. As a follow-up, patient may be taught to a self-mobilization technique for the first rib to be performed as a home exercise program. But these mobilization techniques may reproduce as patient symptoms, and patients are few therapists and clinicians are trying to discourage the use of first rib mobilization in the patients for this reason. Of course, I am not encouraging this as well. Encouraging diaphragmatic breathing helps to reduce the activity of these muscles, increasing the costoclavicular space. Vigorous aerobic activities may increase scalene activity and elevation of the first rib. So we have to be cautious with use of aerobic activities, which may increase the symptoms, especially in the earlier rehabilitation period. Next one, please. The most commonly recommended interventions are strengthening and stretching of the shoulder girdle musculature. However, little agreement exists on which muscle need strengthening and which ones need lengthening. Next, please. Why I am talking about this controversial issue is usually the therapist will be having their own choice of stretch these muscles and strengthen these muscles. They have their own preference, and whichever is their easy or convenient exercises also are there, and they have their own choice. But there is no recipe for this. But what we need to understand is, next slide, please. It's not that the thoracic outlet in the thoracic outlet area only. We have to know the relationship of this thoracic outlet distally in the hand and in the proximally in the trunk. How this thoracic outlet is related with our hand functions and body function. Because if we are focusing only on the thoracic outlet area, just because it's pectoralis and the wrist, where these muscles are having the anatomical facial sling connections, we have to worry about the whole slings and try to address them, try to check where is a resistance and try to release the tightness or try to balance the muscles. Next, please. As I mentioned, for the scapula, we have two controls over the scapula. One is upper and down, like with superior and inferior, with the upper and inferior trapezius and lattice, and here that medial and lateral, which the rhomboserratus sling. The rhomboids is coming and connecting with the medial border of the scapula, whereas the serratus anterior is starting from the medial border of scapula, which forms a sling. And this synchronization have to be developed to improve your scapular stability. Again, please. Again, this slide talks about the how's relationship of this pectoral spinner to the deep facial line, which we have to bother as a whole chain of the functional lines, not only the pectoralis minor. We have to worry about that whole sling. Next, please. And deep front line. When I spoke about the influence of this breathing and scalene, poor breathing will have a negative effect on the entire deep front line and especially on the floor muscles. four muscles: the tibialis posterior, psoas, diaphragm, and scalene. So when you have that apical breathing pattern, that will affect these muscles to get influenced, and apparently these muscles will go on to the compromisation of their function. Next, please. When the diaphragm does not function properly, the client is in upper chest breather. The scalene are one of the accessory muscles that take over to assist in normal respiration. It becomes hypertonic and develop trigger points that can refer symptoms similar to the thoracic outlet syndrome or carpal tunnel syndrome, as well as aches and pains are in the upper back. I must mention about the double crush syndrome when we talk about this thoracic outlet syndrome. We cannot have the single diagnosis, as I mentioned. We have to consider this double crush syndrome as well. Next, please. In an upper chest breathing pattern, the diaphragm does not move downwards, causing the aorta spinae to become hypertonic. This will often cause a client to become hyperlordotic, as there is an increased tone in the thoracolumbar junction. So this is how the whole posture changes, and it affects the whole patterning of your positionings and scapulars. Again, please. These are my references, and thank you. I thank the committee again. It was a really good arrangement, and congrats.
Thank you so much for your wishes for the strike committee, sir, and the organizing team. So we do have some questions from the panel side. Sir, if the panelists have asked, is there any space occupying lesions? So how do we correlate with the thoracic outlet syndrome? So what will be the assessment and the management for that?
Okay, space occupying, we cannot have much role with the physiotherapy, but we have to know what is it. It's safer to know, as I mentioned, we have to first diagnose what is that safe occupying lesion, what is that lesion actually comprising of, and it's better to diagnose it and then plan it. There is no recipe for these things, because unless we have a proper diagnosis of what is that thing, then only we can go for it. But if there is any compression due to any soft tissues or related slings, we can work on that appropriately.
Okay, sir. And the next question is, sir, if the patient is going to present us with the thoracic outlet syndrome, so
Sorry?
sir, if the patient is going to present with the thoracic outlet syndrome, so what kind of patient education has to be provided to them for the management?
What kind of
patient education has to be provided?
patient education? Yes.
Yes.
The first and very important advice what I will select is about the postural correction and the lifestyle modification and pain education. We have to explain the patient about the nature of this condition, and we have to explain the patient about the complication of this thoracic outlet syndrome. It's not a straightforward pain as such, it's a syndrome. So the patient must have a clear understanding about what he can expect from you as a physiotherapist and how the outcome will be, and then teach the patient about how to cope up with the patient. Very important is pacing of their lifestyle, pacing of their exercises and activities. And if you go through the pain toolkit, there are lots of information about how we can teach the chronic pain patient about the pacing. And then we can go about the postural modifications. Like, for example, I mentioned about the diaphragmatic breathing, how the posture changes with the hyperlordosis. We have to alter that breathing pattern, and we have to release the structures according to the requirement, and teach the patient about how to do the exercises, including stretches and not strengthening. Again, I'm repeating, it's only mainly to concentrate on the endurance and muscle balancing exercises.
Thank you for the valuable session, sir. We had a very glad time presentation. Thank you, sir.
Thank you.
So the next presenter for the webinar session is going to be Dr. Vigashni. Dr. Vigashni, can you switch on your video and audio? Dr. Vigashni?
Yes.